Well, hello, everybody. I'm Cliff with the Salute America team here at UT Health San Antonio. As we're giving everybody kind of a minute to log in, just welcome to the next webinar in our webinar series, Let's Address Health Equity Together. Today's webinar is how to systemically address social needs in healthcare settings. Our moderator today is Dr. Amelie Ramirez. Dr. Ramirez is Director of Salute America and its home base, the Institute for Health Promotion Research at UT Health San Antonio. She's conducted much research on human and organizational communication to reduce chronic disease and cancer health disparities affecting Latinos. She's also Associate Director of Cancer Outreach and Engagement at the NCI-designated Mays Cancer Center here at UT Health San Antonio. Amelie, I'll hand it off to you.
Great. Thank you so much, Cliff, and good morning to everybody. We really appreciate your attendance today, and we have a very important topic that really started bringing to the forefront when COVID hit. You know, we realized that a large segments of our populations were not being well represented and really had the social determinants of health were really having an impact on their health. So again, thank you so much for being here. We know that health doesn't start at the doctor's office. There are conditions in which we are born with, that we grow with, that we live with, that we work in, and also our age. And all of these are known as social determinants of health. And each one of these can impact our health. And so it's important to know more about how we can deal with these issues. And we need more health organizations to work with us, including hospitals and clinics, to recognize and to respond to the impact of social determinants of health that has on overall health, especially among our marginalized and medically underserved populations, including the Latino populations of which we serve here in South Texas. And today we have a fantastic panel. I'm really excited that will help us explore the social determinants of health. And, you know, we're going to learn from them about how they are dealing with this in their organization and, you know, what some solutions that they have come up with as well. Today's panelists will include Dr. Carlos Jaén. He's professor and chair of family practice and community medicine department here at UT Health San Antonio. And we have Alex Koster, who is the senior director of value-based care and analytics for the Nemours Children's Health. And shortly joining us will be Dr. Andrea Caracosti. She's the director and CEO of the Hope Clinic in Houston. And in addition, Rosa Viloch Santiago, who is the Associate Director for Community Partnerships with the American Cancer Society. And our first speaker today, who represents our webinar sponsor, and we're really grateful to Genentech, a biotechnology company and a member of the Roche Group. Meg McKenzie, it's been a pleasure to work with Meg for a couple of years now in dealing in the area of inclusivity for clinical trials through the Alliance for Inclusive Participation in Clinical Trials. Meg is in patient inclusion and health equity at Genentech and in their Office of Chief Diversity. She develops strategies to drive greater inclusion of racial and ethnically representative patient populations in clinical research and to advance health equity. Meg, it's such a pleasure to have you here this morning. Share with us a little bit how is Genentech addressing social determinants of health?
Thank you, Dr. Ramirez, and thank you all for coming today to listen to these expert panelists. It's just our honor to be sponsoring events like this, and they're called the Regional Health Equity Symposia. And as Dr. Ramirez is she's amazing, a community educator. We felt it was really important to be able to tackle and address social determinants of health regionally, like what the problems are in Texas versus Los Angeles versus Florida. They could be very different. So I'll go through this really quickly so we can get to our expert panelists. But at Genentech, we have many folks that are involved with improving access to improve healthcare. And access is just one piece, but that's a piece where we're bringing festivals and fairs directly to communities for health fair screening. And we work with sites like Mays Cancer Center and Dr. Ramirez to create health literacy education programs around inclusion and clinical research. And that's kind of my day job, is improving Latino representation in clinical research. so we can ensure the populations with the disease are included and we understand how medicines are working in all populations. And we have policy makers who are on the Hill trying to ensure we improve access to insurance. And our strategic funding group is in giving, and they are doing long-term partnerships trying to come to communities to improve access. So I'll share just a couple of examples of what Genentech is doing so we can get to our expert panelists. One is this Health Equity Symposia. Dr. Ramirez, you've been amazing at hosting 8 or 9 now, specifically to help educate Latino communities around breast cancer, prostate cancer, how to access things that they need. So we have 48 programs across the U.S. this year, and we'll be continuing this program next year so we can understand locally what to do differently to improve access. And then another example is this Fiesta Fair that was done in Texas. We partnered with a local Latino organization and also Prevent Blindness for Texas to do vision screenings, and had folks there to do education on multiple sclerosis, diabetic eye disease, breast, lung, liver, and colon cancer. And I would just reinforce the importance of going to these free health clinics where you can get access to information that just at your fingertips. And Dr. Ramirez, just to give an example for this audience, we had folks lining up at 2 a.m. outside the door to come into this fair. I mean, it's just a much needed service that we need to figure out how to amplify and do more of wherever we are. And we're really honored to be working with these local organizations to try to reach communities in need. Another example would be a health equity and cancer screening. You know well, the American Cancer Society is an amazing organization. They have local chapters everywhere. They're a great resource for patients, and really happy to be among many pharmaceutical companies co-sponsoring events across the U.S. One of them I just brought up was the Dallas-Fort Worth, and there's several events. So be on the lookout from the American Cancer Society. There are many screening events, and that's just one way to, we know early screening, early diagnosis improves outcomes. And so kind of debunking myths around what's involved for screening and knowing your family history, and being able to help your family members as well get to these screenings are a really proactive thing that families can do. The last thing, and then I'll turn it back over to you, Dr. Ramirez, is we're very excited. Our giving group is really trying to tackle head on and reverse past wrongs with racism and unconscious bias and systemic issues with getting access to the things they need. And they're working with local communities. We've created this Community Health Justice Fund where there's individual grants to local organizations who are doing things like addressing food insecurity. And I can talk about that example later on. So I'll stop sharing and turn it back over to you, Dr. Ramirez. And thank you, everybody, for being here today.
No, well, thank you so much, Meg, for Genentech taking a lead on these important issues for our community. We're extremely grateful. And now I'd like to turn to Dr. Hyen. Dr. Hyen, you and I have worked together for a number of years to address the needs of our South Texas community. Why are social needs critical in the health of Latinos and other underserved population groups? Why should healthcare providers care?
So thank you for the question and thank you for the invitation. I'm delighted to be here. And frankly, part of the issue is trying to understand the root causes of what's going on. Our Latino and the people of color communities have been, for a long time, systematically excluded from social resources that are important for health. Some of those resources are physical, or they may be related to food, maybe to housing, to many other components that are traditionally addressed. But we also have multiple ways in which our health systems are exclusionary, and they sometimes poison the notion of trust. And finding ways to recreate or refocus the affirmation of human dignity in the patients we deal with. I like the fact that Megan mentioned humility. I think that that's an important part of that process. And, from our perspective, we take that to heart. Our main clinic is located in San Antonio, in an area that was redlined and where people died 20 years earlier than the rest of San Antonio. That's a reality. They have the highest level of poverty, the highest level of amputations and diabetes. So our response has been to look at ways to address that issue. So yes, we do some social determinants of health screening, but screening is not enough. We need to actually take action once we discover a particular screen. And I like to just give you a couple of examples, and we can expand more when we're having questions and answers. Related to the physical needs, I mean, during the pandemic, we collaborated with the food bank. And once we address individuals needing food, we deliver packages to their doors. And we brought that as part of our process. But more importantly, in terms of building trust, all the screening tests and all the prevention services are not going to be accessed if you are in an environment that there is no trust in the health system, or this health system has systematically excluded you, or you're not really, it has created a culture that is not particularly trustworthy. So we are very intentional in building trust in our community. We have a team of community health workers who are embedded in our primary care teams, and they work individually with patients, not only individually, but in the household, to really look at what is important to them and to build bridges of trust, and then allows us to get to what they need to do. So I think it's important to recognize and to own, from a perspective of health systems and from a perspective of academic health centers, that the injury is there. We need to acknowledge, and then we need to look for opportunities, not only to address the physical needs, but also address the issues of trust and culture. If a culture is such that, I am discarded, I'm not really important, why would I do a test? Why would I make that happen? So we need to find ways to reaffirm that sense of dignity and the sense of deserving the best care possible. And only when we do that, we will be able to make significant progress. I don't know if my time is up, but I'm happy to expand more when the time during the question and answer.
Thank you so much. I really appreciate that, Dr. Hyen. And as you well know, it's not it doesn't happen overnight, and we've had a difficulty in making sure that our communities believe in science, believe in what we're learning from our healthcare practices, right? For them to come and want to seek the screenings and the treatments that our clinicians and providers are recommending. Any thoughts about that in terms of how we can improve that here in our community?
Yeah, so I think that we have to start by living what we believe. So just telling people, well, believe it, I am the scientist, I do it. I think part of the process needs to be a training of our scientists, our colleagues, to use in the proper language and the proper respect in the context. Just rejecting a belief that we think it's not proper just disconnects the conversation. So we need to start by affirming who they are, affirming their value. And only when there's a sense of trust that, oh, you really care about what I do and you really care about what I say, only then can we make changes. Just blasting information is not sufficient. We need to have credible, trusted information. I happen to work in primary care, and that's a place where relationship is key. And building on the relationships and building on relationships that are trustworthy is one of the key priorities to make a difference.
We're seeing a lot of claps and thumbs up. So thank you very much for those comments, Dr. Hyen. Now I'd like to transfer to Alex. Alex, you're one of the leaders who helped implement social determinants of screening at Nemours. What is social determinants of health screening, and why did Nemours prioritize it?
So Nemours formed a value-based services organization to focus both on kind of the contracting side of value-based care, but also more importantly on the population health side of taking care of our children back in 2018. And following that, our CEO set a clear priority. We wanted to help drive for the healthiest generation of children and focus on health and well-being beyond what we call well beyond medicine, beyond just in episodic clinical care. So if we're thinking about population health, you can't do that if you're not addressing the needs of the whole child, and you cannot do that if you leave certain populations behind. It's the model, everything that Dr. Hien mentioned. You can't start out of the gate with an exclusionary framework and with a framework that doesn't address the complexities of need. And from my seat, we kind of fell in a little bit into the role because we were building some of the technology framework to do population health work. And we happened to have the architecture to deliver screening within our EMR and things like that. And it allowed us to kind of jumpstart the process of developing a screening tool. We worked through models with the Disparities Leadership Program out of Mass General. We did several cycles of pilot testing and really tried to sell not only the mechanics, the operationalization of screening our patients, but also one of our key important areas to focus on is what are we going to do with the data and what are we going to do to take action? And so we developed a framework that said, well, at the core, at the foundation is the child. And so if there's a clinical decision that's informed by the results of a screening, the classic example being you lack refrigeration, it might inform a drug that, needs refrigeration. That's an example. All the way through to, is it going to inform a change in policy? Is it going to change process within our healthcare system? Is it going to change what we advocate for at the community level? What partnerships we have? Is it going to change what we lobby for at the state level and services with data? Is it going to change our national position, the national advocacy we do? So it's kind of an inverted pyramid that starts with the child at the foundation, but then looks at the different levels of things we might do. And then to check, are we acting at each of those levels? And so, yes, we're making decisions about someone individually, but then are we also saying, okay, what if we made this change within our clinics or this change within how we look at data? And then have we done things like open food pantries or implement a medical legal partnership? That's where we're making system-wide investment and then onward and upward. So we really started there. The screening tool itself is embedded in our clinical workflow within primary care, within our electronic health record. And we developed an analytics framework to really look at everything from not only positive responses, but what rate of patients that were due for screening received it. So we can look at workflow all the way through to can we look at equity and disparities? Who is identifying a need in what community, what population? At the click of a button, can I tell the response rates and needs rates for predominantly Spanish-speaking populations versus English, or our African-American population versus our other population? So it's really wrapping all of that together into one framework.
Wonderful. That's awesome, Alex. And a big question for you is, how do you motivate personnel to utilize the screener?
So that it's not easy. So it's partly making sure that we're clear on what to do. We built a framework that said we would not roll out our screening tool to any clinical area that didn't have what we call a tier 2 escalation. So any area that rolled it out had to have access to a team of social work or care coordinators that they could escalate or refer through the screening process, people who had needs to help curate and manage accessing services. So we had a lot of areas early on who were interested in, but they said, well, I don't know what to do if someone has a need beyond, maybe I have a flyer or something. What else do I do? So we decided early on we would not roll it out to any area clinically. We're a large health system that did not have an escalation point. And that escalation point is then built into the EMR. It's who gets the in-basket message.
Right.
When a need is identified within the clinical workflow to support the needs of a patient or family. And by doing that, we're protecting. It's unfortunate, but it is real. There's a part of this work that is protecting the psychological well-being of the care teams, because there's a tendency to despair faced with the enormity of the need. And if you're saying, well, go and face that enormity even more, but we're not going to give you the tools or the resources to address it, then you're actually making adding yet another problem to an existing set of issues. And so that's been part of our model, and it meant going a little slower than we might have otherwise in our deployment, because we had areas that simply didn't have those resources available, even if they had interest and willingness and mission commitment. And it's like, until we can resource you, we're not ready to have you embrace this to the same level.
Okay, well, great points. Thank you so much. And that having those connections to who's going to follow up is critical. So, Dr. Garracosti, thank you so much for joining us today, and good morning. With your work there you lead a federally qualified health center there in Houston, which has a large Latino population. How is the social determinants of screening helping you with your patients? Could you help describe that?
Absolutely. Hope Clinic is located in Houston. We are second largest federally qualified health center here in Houston. We also provide care not only to Hispanic communities, but also to a large amount of Asian Americans and refugee patients. So the social needs of our communities are really magnified. Some of the things that we do to really address the social determinants of health in our communities are certainly, of course, we've been using the Prepare tool for a number of years, maybe 4 or 5 years now, and really trying to understand not only what our community needs are, but also prioritizing the patients that need it the most. And I think that the danger in trying to be all for everybody is that those who need it the most end up in the last place on the list. So we're really right now using different tools, different data aggregation tools like Azara and other products that help us stratify our patients and look at who are the neediest and the most urgent to take care of, and surrounding those with additional resources to get their needs met. It's no question that a lot of people need a lot of things. However, I also think that in tandem with that, a really an interesting strategy that Hope Clinics has had for the last 3 years is our management on upstream health. So we're trying to really bridge the gap between the walls of the clinic and the rest of the community, and trying to work into community development strategies and strengthen our community, because ultimately what we want is not just to have a revolving door of referrals for social services, but really stronger communities and more resilient communities. So in that effort, we run a program called the Bite of Hope program that has those 3 components, four components, but 3 of them are inward facing, like food for prescription, referrals to pantry, voucher programs. So our providers do write those prescriptions for food or transportation. But we also have a community program that we work with the schools in terms of providing education to the parents, nutritional and cooking classes for the patients and the parents, and then the outward facing and more innovative part where we work with small businesses in our community, helping them create healthier meals. And we also run a culinary institute, helping people have opportunities to get a chef certification and then be able to move up the socioeconomic ladder. So really trying to bridge that continuity between what the needs of the patient are in the clinic, but also trying to prevent more needs of occurring.
Those are wonderful partnership ideas that it's needed, because like they say, it takes a village, right, to make a difference. And so that we all need to work together to make sure that we synergize the resources and opportunities that we have within our community. So thank you so much, Dr. Garracosti. And now I'd like to turn to Rosa. Rosa is with our American Cancer Society. And Rosa, can you share with us what the American Cancer Society is and how they're addressing social determinants of health and social needs? And she's joining us by phone, and we apologize for the technical difficulties.
Good morning. Buenos dias. Can you hear me fine?
Yes, we can. Thank you.
All right, thank you. For we at the American Cancer Society and its nonprofit, nonpartisan advocate affiliate, the American Cancer Society Cancer Action Network, health equity means that everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. And that means providing specific tools and resources based on individual needs to allow everyone to the opportunity to be as healthy as possible. And to that, we are addressing social determinants of health through our research, our advocacy, our partnerships, and through our patient support and services. One example is about 2 years ago, we've actually created a screening for social determinants of health guide and assessment tool where we're supporting our health systems and cancer centers with implementing and improving the screenings for this. We pilot tested it back then, creating through a communities of practice. And since then, we've worked with health systems that can use the toolkit to identify opportunities to improve the systemic screening for social determinants of health within their systems. Another example is through our National Health Equity Ambassador Program. And that program promotes cancer health equity and reduction of cancer screening disparities through community outreach and education. The American Cancer Society and partnering organizations work together to mobilize the volunteer workforce of trained health equity ambassadors to help underserved and individuals and communities to prevent and find cancer early. Through the Health Ambassador Program, we are providing linkages to community health resources. We're increasing awareness of the importance of different types of cancers and clinical trials. And also we're informing communities about their cancer risk. And also we are helping them identify what are those social determinants that are actually creating a burden for their access to cancer screening.
Great, those are wonderful ideas. I love the health ambassador approach and really helping the community to connect. But now we'd like to you all have given us some wonderful thoughts to think about, and now we'd like to open it up for some discussion across our panelists. Anybody who would like to put a question in the Q&A, please feel free to do so. And we have a couple of already questions that have popped up. So Dr. Hyen, in your experience, what have been good strategies to increase trust with patients?
So now in our clinic, we have a program that we call the Nosotros program. It's a way in which we have a referral to a community health worker who is embedded in a primary care team. And that community health worker works with a particular patient, and initially it was a diabetic patient, and they work at their home. They develop a relationship, and they don't start by talking about disease, but they talk about what is important to you. What do you want to be? What do you want to do? What are the things that you want to accomplish with your current life? And who else is in your household? How can we include them in that context? And only after that relationship is formed and there's a sense of trust, then we can talk about the disease management. We have done an evaluation of that project. We had over 900 enrollees, and we followed them over 4 years, and we were able to demonstrate significant changes in the ability to manage diabetes, but also in their ability to feel better. So trust is something that is easy to break and is hard to build, but it requires that personal affirmation, that getting to know. You cannot trust someone who you don't know. And sadly, for many of our patients in the communities we serve, they have had negative experiences where their value is discounted, or they are seen only as a number, not as a person. And our approach is whole health. So we looked at the whole person, and we used that as an initial component. In addition to that, in a similar way as Dr. Karakostis, we also have a community outreach program where we talk about Nuestra Mesa. We go to some schools, and the focus there is to build within families the ability to communicate and value each other. Part of the stress and part of the pressure that comes from the social conditions is that you learn to be devalued, and then you sort of turn that against each other in the context of the family. We are very mindful of the fact that there is a lot of trauma that has been generational, and to the extent that we help promote a better communication and connection, all those pieces I think help towards building a trust, and trust not only in each other but also trust in the health system, because now I can trust my physician or I can trust my clinician to give me what I need in that context. In that space, then if I have a trusted clinician, I can then potentially, if you're talking about cancer screening, but also any other kinds of preventive services intervention, then I'm more likely to trust you rather than to actually do it, because then I feel like this is really in my best interest and not necessarily in the interest of a system that often devalues me and sees me as a way of producing wealth.
Oh, so true, so true. Thank you so much. Meg, there was a question about how can different organizations partner with some of the events that might be occurring that Genentech is helping co-sponsor.
Yeah, I added my email so I could find the right people. So we do have folks who work locally in all areas, and I can connect anyone who's interested to those local folks. We also partner, as I mentioned, with a lot of organizations. Just to add on for the importance of community, promotores and patient navigation, we've been told over and over and over again how important that is for a community health worker and outreach. So we work a lot with promotores who are going into med schools to build cultural humility in the med school, with working with different cultures, including our Latino cultures. But definitely, Dr. Ramirez, you could email me and I'll find the right people. There are multiple people that are working with American Cancer Society, and also American Diabetes Association, and these local fairs. I think the question came up with how can nonprofits get involved with some of the local fairs. So yeah, I'll find the right people depending on where you are.
Great, thank you so much. And now I have a question for Dr. Karagostis and for Alex. How have you gone about creating culturally tailored materials for social determinants of health screening and resources? And how do you discuss the need in a sensitive manner?
That's a loaded question, because patients do have pride, and not always are they willing to disclose how they feel about the questions that we ask that can be quite intrusive. We've gone through different pilot projects while rolling out our Prepare questionnaire, especially looking at where and how is the best way to ask these questions. We've tried from paper forms at the registration desk to, having the medical assistants ask the questions, the care coordinators ask the questions, when to ask the questions. So I think that it is not one shoe fits all, but I think, and also different cultures respond different to different questions. We've done a survey with our Vietnamese community, for example, and when you ask them if they have any needs, they never have any needs. They're always very healthy. But when you go into the back office, then certainly they're willing to open up about their challenges with transportation or food. So I think it really depends on when and how you're developing and deploying that questionnaire. We chose to deploy that questionnaire at the back office with the medical assistants, because the patient has more privacy, and they're not rushing through the questions at the beginning where they just say, oh, let's just say no to everything so we can get through, or let's just say yes to everything so we can get more resources. So I think that way we really can identify the needs of the patients where they are. And then we, of course, have to take action on those needs. And that at the beginning was a real burden on our physicians, who felt that they were bombarded with additional things they had to fix. And I think that that's what providers feel, is like you give them something broken and they got to go and fix it. And that was another road of, how to deploy the questionnaire. And I think that by now people understand that it is not really about fixing everything, but really about understanding what patients need and want. And one of our strategies to help bring the needs, the social determinant needs, to the forefront and understanding of our staff, we started doing what we call walkability studies with our staff, our board, our physicians, our front desk staff, helping them, getting them out of the clinic, walking around the neighborhood in the heat, and giving them a form to fill out, really highlighting the challenges that they would have under different circumstances. For example, incomplete sidewalks. If you have a mom walking to your center with 2 children and there's no sidewalks, then they may take longer. And if it rains, they may not show up because they won't be able to cross that puddle and they know it. Or if it's too hot and you have a patient coming in on their wheelchair, they may not show up or they may be late. But I think it brings empathy into the clinic, and having empathy allows you to relate to the patient's needs and be able to craft solutions and accommodate their needs to the reality of the patient care. So not always is, having to solve the problem for them. Sometimes it's being able to be empathetic to the challenges that they have, and we all have when accessing healthcare, whether it is fear or, even people who are employed and insured, like we probably all are, we still face barriers of not having enough time to get to the provider, not having the right scheduling. So I think that there is that built-in kind of lining behind social determinants of health that we've forgotten, and we do need to build in within the ranks of healthcare provider places.
Alex, would you like to add?
What I would add is I'm furiously taking notes going, I just wanted to say what she said and then do half of what she said and add it to what we do. That was a magnificent and well-informed response. I would say understand the populations you serve. That is both the walked awareness, but also at the high level, if you're going to have some corporate or enterprise entity making decisions or implementations, then they need to be well informed by what they're doing. And so understanding the communities that are being served, understanding that there isn't one answer, being ready to change what you're doing and come up with a better way is critical as well. And so and that isn't necessarily saying that what was done yesterday was wrong. It just means that it could be improved upon. And I think that that's somewhere we are. We're at the cycle of taking back and harvesting the lessons learned and what did not work well at different clinics with different populations, and saying our approach is working well in these settings. In these settings, we're creating friction or we're running into those trust barriers. And also understanding, I really like the point about the empathy and the listening. So the assumption that the expectation is that if you're going to ask and identify a need, there's an expectation that you will solve all of it is not necessarily the case. And the act of understanding the barriers someone faces and addressing with empathy is in and of itself part of delivering good care. Even if you can't come up with money to pay rent that month, it's not necessarily did they expect you to do that, but you are still meeting a need to an extent, even if what you're able to provide is here's a service that can support you possibly. But I really love the prior response, and I'd encourage everyone that is well informed in the path to follow.
And I liked your earlier comment, Dr. Carrascosa, in terms of helping prioritize, and Alex, in our conversation before we got started, that providers also, and all the support teams that are helping address these social determinants of health, that each one is a win. We may not change everything for that individual, but if we are making some progress, that even our healthcare teams, right, need some positive reinforcement as well. So I appreciate your all sensitivity to these questions. In terms of Dr. Carrascosa and Dr. Hyen, how difficult is it to get buy-in from your clinics and your providers to do this screening?
Want to go first, Dr. Carrascosa?
Sure. It's not easy. I think it from many points of views, right? For the patient, because the visit may take a little longer. And from the provider, because of course they feel obliged to do something about it. I think it takes time, and it takes finding a champion, rolling it side by side slowly. I don't, sometimes we're pressured into checking the box and saying, oh, I address social determinants of health check the box, ask them the question about food, check the box. We live in that world of, we call it value-based care. And we forget that the value is not for the bottom line. Yeah, bottom line is important, don't get me wrong, but the value is for the patient. The patient is the one that needs to check on the box and say, hey, I feel that my visit was worthwhile, and I feel that I was heard. And whether we can satisfy those needs at that point is important, but it's more relevant that we understand and we build long-term strategies for change. Developing a rolling door of referrals to different social agencies and offloading our responsibilities to another organization does not solve the problem. And I think that involving your workforce, involving your providers, and thinking out of the box and thinking, what can we do so that, we really can reduce the number of people potentially getting diabetes in our community? How can we change the way people eat, for example, not necessarily the meals that they consume, but that they take time to cook with their family, that they take time to sit around the table, that they take time to understand what the richness of food they're sharing, and emphasis on the word sharing. And then encourage small businesses to see how powerful they are when they feed so many people out of their restaurants. So restaurants have a huge amount of power in delivering food to all of us. I mean, I want you to raise your hand and let me know how many of you don't eat out at least once a week. We all eat out at least once a week, or take out or drive through. So people who have small businesses in neglected neighborhoods have a lot of power over those neighborhoods to provide good food. So I think that working with outside the clinic walls and addressing those needs, working with your staff, because the staff wants to eat healthy too, really makes a big difference. So I think that when people understand the challenges of their patients and they can look outwards and say, oh, in addition to the care, I can be part of this other solutions, I think we make a larger stride.
Thank you so much. Dr. Heying?
Yeah, well said. We have a similar approach. I would say that the most important thing is to not make it, don't make the clinician make it, do it, because it won't happen. So if you want anything done, don't give it to the clinician. Build a team, be in a support, make it easy to do the right thing. To the extent that this is an addition to the competing demands of providing care, it just doesn't happen, or it happens like she said, I'll check the box, but that's not sufficient. So to the extent that we can have a team, in our situation, we have behavioral health consultants who get engaged and they're integrated in primary care. We have, like I said, community health workers and we can address, but also the constant dialogue and the constant work in the community to address food, to address preparation, to also address community building. I mean, community building is an important part of health. And to the extent that the communities are desegregated or they're not particularly integrated or connecting, what is the role that we can play in promoting that particular process to make it work? And so our clinicians are very mission focused, and you can be very mission focused, but you still have to get through whatever it is that you're trying to get through. So finding a way to align the mission with the process so that it's easy to do the right thing, that's an important piece. And whether you engage the electronic health record or you engage the other members of the team, and really share the notion that we all own this issue. It's not just for the clinicians to solve. It's not just for us as a group of professionals to address it. It's all of us. And when my patients come to see me, they are also the patients or the medical assistant and the front desk person, and everyone in that team has a role. And to the extent that you empower, not necessarily empower, but you allow them to see the value of what they can contribute, that's going to happen much more effectively than if you just say, okay, well, doctors, this is what you need to do, or nurse practitioners or PAs, this is what you need to do, because that just gets into the bottom of the list and never gets done. And what we want to do is we want to be responsive in a way that makes a difference, because ultimately is about healing. Ultimately is about promoting whole health. And if we're not doing that, we're not really doing our jobs. But it's not easy, but it's doable.
Thank you so much, Dr. Hien. A question for Meg and Rosa. What else can we do to support the healthcare system that want to implement these tools for social determinants of health screening? What thoughts do you all have to help be supported? Meg, we'll start with you, and then Rosa.
Yeah, thank you. Yeah, with social drivers of health, we're recognizing how important this is for health outcomes. So some of the things we're doing are supporting organizations to drive surveys to collect social drivers of health information from their patients, from housing insecurity and quality to food insecurity. Another thing that we're doing is including, Dr. Custer mentioned it, including collection of that data wherever we are. So in our clinical studies, especially our medical affairs studies, the zip code, education, income. So starting to measure what you treasure, right? Start to collect who your patients are and what their concerns are, and then we can help develop systems that can help those patients. And part of that coalition I mentioned, the Community Justice Fund, Rise to Health, that's a partnership with other larger organizations that are really looking at social drivers of health. American Medical Association, the Institute for Healthcare Improvement, the American Hospital Association, and Race Forward. So I'll put these organizations in the chat, but these are organizations right now who are going to be doing a lot in the next couple of years to expand the use of collecting information like social drivers of health, and then figuring out how can we reach communities to improve them. So I'll put those in the chat, but it's really partnering with everybody, and then understanding locally what the concerns are and trying to tackle those locally, because they're very different perhaps in San Antonio than they will be in Miami. But that's how we're going about trying to move the needle.
Thank you. Rosa, would you like to add some comments?
Yes, absolutely. As we all know at PERP here, addressing all of these issues are, they're very, we just cannot do it, by itself. They're too complex for any organization to address it on its own. So that's why, we have created, and we are uniting organizations in partnerships through our national roundtables and through a variety of convening models. The ACS National Roundtables, we're bringing together diverse multi-sector partners to catalyze collective action towards improving population health and advancing health equity and addressing social determinants of health. We currently have 6 roundtables focused on colorectal cancer, breast cancer, lung cancer, patient navigation, HPV vaccination, and cervical cancer. So if you want more information, you can access our website, cancer.org/national roundtables, and you can get information on how you can actually be a member of any of those roundtables. Another area or another example that I can offer is through the work that we're doing in the field, working with partners through our community impact efforts. And we are leading partnership development and promotion and implementation of our programs, delivering evidence-based strategies with health systems to address the social determinants of health throughout the cancer continuum. An example of that is our long-standing partnership with the NFL on our Crucial Catch program. Money raised through that Crucial Catch program actually supports our efforts where we work with primary health systems, specifically federally qualified health centers. We work with them to address cancer early detection through community-based and evidence-based quality improvement interventions to help and to promote and support their efforts to increase cancer screening. So right now, we have around 30 to 32 programs throughout wherever there is an NFL team in every of the markets. And we actually work with the primary care system, healthcare systems to help and to find ways to support and address social determinants of health as well. Another area is through our advocacy and through the work that our Cancer Action Network is doing at the state, local, and federal levels. And just earlier this week, we had over 700 volunteers representing the 50 states, one in Puerto Rico, right here in Washington, D.C. This is where I am. And they met with their members of Congress to urge them to prioritize the fight against cancer and to advocate for adequate funding for cancer research, for prevention programs, and for improved access to life-saving cancer screenings, especially for those at high risk. And we also are, I was just adding that we're funding at least 61 health disparities in our research area. We're funding at least 61 health disparity research grants to help us better understand, where the disparities exist, what causes them, and how to decrease them.
We're fortunate that we received one of the American Cancer Society's Centers for Health Equity. So thank you so much. And we're focusing on social determinants of health. So we're excited about that. Thank you.
We are.
I had a question again for Dr. Hayem. We've got a few more minutes. And also Dr. Karakoski, can you please share with us a story about a family that has been helped through this screening? So Dr. Karakoski, we'll start with you, and then Dr. Hayem.
We have certainly plenty of stories of patients that had no transportation and were benefited from our vouchers or Uber Drive. But I think most importantly, I think is a systematic way of changing the. We've had a patient that certainly chronic care, diabetic patient, mother and daughter. And patient of ours that they started getting some of the food vouchers from our FoodRx program. And we learned from them, of course, that a lot of the food that sometimes you give people are not necessarily the things that they cook on a daily basis. And they had challenges, consuming the produce that we provided them because it was not within their dietary routine to eat those. So I think they by providing guidance with the chef and helping them eat prepare the products that they got in a better way, they were able to consume and add new variety of products to their diet. But one step further, when we opened the Culinary Institute, both of them were two of the students that came and joined the class because they were so motivated about the changes that they saw in their own diet that they decided that they wanted to learn in a more professional way how to prepare and engage other people in eating healthier. So during this culinary class, they not only learn the preparation of the products, but they also learn how to manage a business and prepare food in advance, how to substitute sugars with other non-high glucose additives, such as let's use a carrot in this cake to add some of the sugar instead of adding simply more sugar to it, or substituting some of the carbs and the fats for different substances that will create the same flavor and the same consistency of the food, but yet are healthier. And so they will be graduating in a few weeks, finishing the culinary with a chef certificate. And I think that's a success story to me because they went from being a diabetic patient to speaking up about their challenges, getting food for prescription. I mean, you think that you're giving them healthier food, but then you forget that people got to prepare those products and they may not be in their dietary. So we learned a lot from them, and how seeing them embrace that change and then want to give back that change is quite amazing to me.
Thank you so much. Dr. Hayem?
So we have a similar story with the food. We partner with a food bank, and they actually had a food truck that was stationed in our parking lot, and we would give prescriptions, and then they will go and collect the healthy meals or the healthy products there, and that was helpful. And we did a study, we followed them up, and we found that we did a randomized trial where we were able to demonstrate that diabetes was better controlled if they were given a prescription. But specifically, I think that I would say one of the things that we were able to experience, and I don't know if we're going to have access to the list of the participants, but I'm happy to share the article with them, is that we took, like I said, 936 out-of-control diabetics that were just very high. We worked with them for about 12 weeks. We followed them over 4 years, and 30% of them got to the point where they understood numbers, they understood food, they understood physical activity, they understood trusting the doctors, the medications, they can explain and connect. And that's a very large proportion of folks who then had significantly less hospitalizations and visits to the emergency room. And more importantly, they felt that they had a handle on their condition and they were able to achieve the goals they needed. In some cases, we get very specific. So someone who is homeless, who is one of our patients who needs a colorectal cancer screening, and it's already past and he needs a colonoscopy, we also have a fund that we support in our clinic for specific issues related to patients. So we then pay for overnight in a hotel so he can have his prep, and he was able to get his procedure. Another patient needed to have he needed a stent for his cardiovascular disease, but the surgery was not going to have, or the procedure was not going to happen unless his teeth were fixed. So we paid for his dental care in that context. So it really is multidisciplinary, it's always very individualized. And I think it's an important opportunity to really be responsive and to get what they need.
Great. No, thank you. You all have just been an amazing panel. We could go for another hour. I have other tons of questions, but we just have a couple of minutes here. I'd like maybe just a very short response from each of you, so because then I have to do a short wrap up. But we know it's not just about screening. Some of our patients need treatment. So how do we address the critical issue of lack of health insurance among our patients and getting them the treatment that they need? And I know this is a complex question, but if you could just give a short answer. We'll start with Alex and then Andrea and Dr. Haya and end with Meg and Rosa, okay?
So in our case, it's ensuring that the people on the front line who are addressing the need are connected to the teams that can connect children with insurance. So whether it's they're facile with Medicaid or other services, or our own internal programs to resource children that don't have coverage. So they have to have that at their fingertips. It's easy to move and provide that support.
Great. Thank you. Dr. Karakowski?
I think that's a really sad situation of the reality of our healthcare system, right? I think it has to do with the immigration status of many families that are not able to get the insurance they need, and they're left really. I mean, I'm very grateful to serve on the board of Harris Health, which is the hospital district here. And I know the hospital district does a lot to serve the indigent patients here. And they are the #1 referral source for all the FQHCs for patients who do not have insurance. Clinics like us do take all the uninsured patients, and we take the burden of providing care to them in a high quality fashion for very little money. And so I think that we're kind of the backbone of the healthcare system. But when patients need bigger surgeries, they have bigger problems, many times there is no real solution to that, especially if they live outside a big hospital system that does not have the resources. That's why many families cross the border and go get care in Mexico, or even go to Canada. I have friends that go to their home country in Europe to get dental care, because it's even with insurance, it is unaffordable here. And I think that it needs to be called what it is. I think healthcare should be accessible to all. It should not be should be a right, not a privilege, to be able to get affordable and quality care. So I think that's why I do what I do, because everybody should have access to world-class care in this very wealthy country of ours, and it is a problem.
I think you're answering for everybody. I'm going to have to bring an end to our panels today and to our webinar.
One word: vote.
Definitely.
Medicaid expansion.
Y'all have been amazing. As you can see, this is a very important issue on, addressing social needs in clinics and hospitals and within the healthcare setting. And we're doing our small part too. We're actually coming up with some information that if your system is not using a screening tool at this time, we hope that you will, stay in touch with Salud America. We will be releasing a toolkit on how to go about addressing this and helping clinics implement this program. Again, a very big thank you to our sponsor, Genentech, for making this webinar series possible. And we have the webinar series. We did record it if you want to share it with anybody else. And you can find it on salud.to/equity webinars. So mil gracias. Cuídense todos. Thank you so much. Everybody have a wonderful day.
Gracias.
Thank you.
Thank
Gracias.
you.
Adios.
Take care.
Bye-bye.